Good afternoon, everyone. My name is Fritz Heimberger. I'm the Global Industry Lead here at Appian in our healthcare provider practice. Just wanted to welcome everybody to our afternoon session here on talking about the ART project with psHEALTH. Here with Ingolv Urnes from psHEALTH. Ingolv is a founder of psHEALTH, has been working with Appian, I guess, for the better part of 9-10 years now. Yeah. Had a previous stint, former life at Goldman Sachs back in the day. But healthcare was calling. So Ingolv has been working with us. We've done myriad projects with psHEALTH, and certainly wanted to share with you our latest and greatest, and look forward to a chat after the presentation. So take it away, Ingolv. Thanks very much for being here.
Great. Fabulous. I mean, it's a bit of a graveyard shift after lunch and all that stuff, but I've certainly had a fabulous conference to date, and I'm quite excited about walking you through a particular project that we've done with Appian. I guess the plan is I won't stone you to death with PowerPoint, so we'll make sure we'll get plenty of time for questions at the end. And I just very quickly on our journey. So we started 2009, and the business philosophy of psHEALTH was to say, let's take a platform and build building blocks for healthcare. And I prefer to say we did that quite successfully. A sort of a spin out of that, and the truth. So I make the differentiation here between building blocks, and when we come to talk about ART, which is the product I'd like to talk to you about, is much more of a proper product. We started that, and that manages a referral management process. I'll get into a bit of the details, and some of the technologies we leverage. And then I guess the last thing we are doing is we're excited about the growth in the Appian ecosystem. So we are also starting a professional services business headquartered in London, where I guess our aspiration is to become a very credible partner in the European ecosystem. The ART and the challenge that this product is solving. So if you imagine, and this is UK specific, but I think it applies to many healthcare economies across the world. In essence, what you have on the top is you have family doctors, or GPs as they're called in the UK. And you go to your GP and he makes an assessment, and he may send you on to a service, secondary care, hospital, community clinics, et cetera, et cetera. One of the interesting things is, so the NHS, the National Health Service in the UK, has worked quite hard on trying to digitalize some of these processes. But really what is missing, or has been missing, is some kind of control in the system. And you can imagine when, and obviously we're talking about here a national healthcare system, but when it sort of becomes easy to make the referral, but money is very, very tight. So the upshot of that is that people at a sort of local level get together and create these single point of access or referral management centers. So they sort of insert themselves, and this is probably feeling a little bit more like moving towards a little bit more of an insurance model, with as a concept of entitlement or what's an appropriate referral. So when we first saw this, it was a very, very manual process. So you had small call centers, people logging into some national health systems, taking a referral package from a family doctor, flicking through policy guidelines, etc., and trying to establish whether is this an appropriate referral, where should it best go, etc., etc. And I kind of thought this is just perfect for kind of an Appian workflow process management approach. And that's when we built ART, which is Advanced Referral and Triage. And I guess our mission is really to help our customers get the right patient to the right place first time. And in this there are many tricky challenges here. There's a big challenge around integration. So there are many old legacy systems and lots of not unwilling partners, but nobody to finance the development of APIs, et cetera, because these systems are a little bit, they're drifting a bit. Obviously, we wanted to do as much safe automation as we could. And then lastly, we wanted to help make the clinical decision-making process. Now, this isn't about diagnosing symptoms, but it's in essence trying to evaluate whether we're sending the patient onto the right pathway. Fritz, you let me know whether it's too fast, too slow. I'm looking at the clock.
You're good.
Make sure we got time for some question. So I guess our mission is this whole thing about safe automation. And when you go back and think about the hub I described, it would be quite common that the human interaction for a single one of these referrals could be easily 10 minutes on average for a particular type of referrals. So you have a lot of manual processing. And when we are driving towards the safe automation, what can we automate completely? Where can we provide sufficient decision-making support that an administrator can review the matter? And then lastly, when do we need to go to the clinician? Because obviously the clinician is by far the most expensive and hardest to manage in the UK. So that's, and by this automation, clearly we want to drive down cost. Consistency and scalability is a big thing because you're starting to ask operators to make really complex decisions based on many, many parameters. It's almost at the border of being unfair to ask the human to do that. And lastly, we think the kind of better analytics is a critical component here. So the process end to end is in comes a so-called referral letter, which you got a couple of examples on the left. The challenge we have is that none of this is really standardized. Okay, so you get hundreds of differently configured GP systems spewing out letters, all sort of maybe using a template of sorts, but they're all different. And then obviously you got through, I'll talk about the process in detail, but the job then is to evaluate where does the GP says, I'm going to send this gentleman to the following orthopedic clinic. Through this process, we want to establish, is that an appropriate path? And maybe book him, and maybe go back to the doctor and ask him some questions. So that's the process end to end. And I guess when we talked about this particular, talking to you guys about how we've used different technologies, I wanted to show you some examples of that. And of course, we're very, very proud of what we've done. Other people may think it's not worth that much. But so what we do here is RPA. So I talked about these sort of big legacy systems. So we have gone from thinking about RPA as a sort of necessary evil to really thinking about it as a key part of our strategy. And of course, when I'm out pitching this to customers, they go like, "Oh, but we're working with this system, and that's never going to work, and we're still waiting for the APIs, and we applied for those in 1996." I feel we can now with pretty good confidence say that we can connect our process to that referral management process using RPA. And would you believe it or not, we do exactly the same thing on the outside. So this is partially dipping in and out of the same systems, partially extracting information from one system and putting it into another system. And maybe for questions, we can talk a bit about more of RPA. I mean, I guess where our RPA experience may be a bit different from other speakers is that we're not really engaging with systems that we control, and not necessarily with completely friendly, there's lots of lethargy, etc., which makes the operation of the RPA a little bit more of an operational challenge. And I'll show you a little bit about how we've dealt with some of that. And of course, this is run, the full process is orchestrated by Appian. In our case, we're using Automation Anywhere because we kicked this off. We've been fiddling around with RPA for quite some time, sort of before the Blue Prism partnership was formalized with Appian. So that's step one, RPA in, RPA out. We then use, we get this package of information, and we're using an OCR with a machine learning template recognition solution to help us structure the data. And I mean, sometimes, so imagine you've got these sort of hundreds of templates, this is what I want to do with the patient, and then the doctor just presses export on his system, and you may get between 0 and 20 or 30 attachments, okay? And you get all this kind of in PDF, and you can imagine now if you're a human being sitting on the receiving end of this stuff, you could spend 5 minutes just trying to figure out where's the referral letter that describes what the doctor wants to do, and then you're wading through X-rays from the past century. So that's step one. So step two, data extraction using OCR. Stuff comes back to us. We have a little lookup. So this is where we do have APIs in terms of checking the spine to make sure that the patient's identification number is correct. We then go through, we partially structure the information now, and we now are using an NLP light to figure out what exactly is it that the doctor is requesting. Is this an orthopedic consultation with an orthopedic surgeon? Is it physiotherapy? Is it a particular type of scan? And then comes the last bit, is we have in Appian built a rules engine, which then in essence, we got the structured information, we now know it's the right patient, we think we know the reason for the referral, and what we do now, and the reason why this rules engine from a customer point is important, is that obviously this varies in every single local health economy. So you'll have different policies, and part of the reason why I was attracted to this business problem was that in Europe and certainly in the UK, healthcare expenditure is obviously growing at 3, 4, 5%. That's not matched by tax receipts, thank God. And there's now a need to make sure you spend money more carefully. And that also means that there's a push to more treatment outside of hospitals, sort of lower cost, lower intensity treatments. And a lot of that stuff is coded into the policy manuals of a so-called clinical commissioning group, which is the regional health board. But of course, it's incredibly hard for whether you're a clinician or an administrator to sort of keep on top of this. Yeah?
For your NLP services, did you home grow that?
We need to hold questions till the end, or you get a microphone.
I'll start thinking about the answer. The answer is that we have made different attempts of trying to do some homegrown stuff, which we found, which is kind of sort of the geek's first reaction, and I guess we've often reverted back to what is sort of off the shelf stuff we can use, and I guess the best example of that's probably in the data extraction side, because once you've extracted the data, actually the referral reason isn't that difficult, and for that we're using OmniPage with I can't remember what the particular machine learning component is. But we started that as well with a homemade solution, and we quite rapidly just found out that that wasn't the right thing. So I guess what we like about this is sort of orchestrating the process really tightly and trying to use kind of the most sensible inputs during the journey. And then lastly, and then the triage decision, and then basically that's a booking outcome, and we say, okay, book patient into XYZ service. So that's a quick run through what the process looks like, and then what's the value of automation? I mean, I'm going to show you just a couple of examples quickly, and I think maybe I have to speed up a bit. But pre-art, okay, so you're looking at 6, 7, 8 minutes to run a particular checking of a particular referral, and that now takes no time. Okay, so this is the example where we have a relatively straightforward physiotherapy referral. We can use all the tech to sort of work it up, and we can safely make the decision and book the person in. And we think that's pretty cool. And obviously, we're saving time. The other bit is this just consistent decision-making, tracking SLAs. So often the hubs that operate these single point of access have committed to quite strict SLAs with their customers, but they really have no way of measuring it. And obviously, this is driven by the rules engine, which is not what's powering the computer here. And so what you got here is basically, so this rule name, when we talk about automating straight through, so it basically says here, skip triage for ophthalmology. It's got then a bunch of different conditions where that applies. And that's when you sort of process straight through. And then the finished product is, patient has been booked, ophthalmology, had cataract, it was routine, he's been sent over to secondary care. You can see the arrival. So this came in via RPA. It was verified by the PDS, which is the spine service, and then you got the details where he's booked. Now that shows you that's, in an ideal world, we want to work towards doing everything automated. But as I said initially, it depends a bit on category. We're probably sort of in the 30% of our cases we can run them straight through. The more common use case right now is we get to about 75%, but which is still pretty good. So you got pretty much the same process, but the big difference here is you sort of inserted some clinical work. And what do we do? Okay, we're sort of shaving off all the unnecessary work, but we're still having to spend a little bit of time with the clinician. And the way that works same benefits, of course, is in this case, okay, so this is GI liver, gallstone, assemble, send it to the clinician, but assemble a short list of options is really what this does. It's quite cool. So the UI then for the clinician is as follows. So he's got all the details. In the olden days, he would have to go into a couple of different systems and look up. You can't see it because we've cut off, but on the, oops, no, that wasn't me. Is there something with the battery on the laptop? Okay. On the bottom here, you'll have a sort of document viewer, so you can scroll through all the attachments. So the Omni page kind of structuring of the document will say, this is a referral letter, this is the X-ray, this is X, Y, Z. Should I just, should I do anything with this, or? Okay. Okay. Well, let's press on, see what happens. Yeah. So that's the and you can see over here when it comes to so this is, I just want to show you this. So here is, we got all the information for the clinician. He can be looking at notes, etc., etc. And then what the rules engine has developed is like, these are, for this particular referral, these are your 3 options. And of course you can say none of these are right and there's an escalation process. But the feedback from the clinicians are like, this is beautiful. I have the stuff that I need to execute on just in front of me. And of course from a, I guess, payer point of view is maybe the term in the US, is you're now starting to have a bit of control over, he can't go completely crazy where he or she, where he's sending this patient. So I'm hoping that makes sense. Just thinking, just sort of wrapping up, and just wanted to give you a quick sort of snapshot on the back end of this. So this is the back end of ART, and I wanted to show you a bit. So obviously we got some configuration with some systems where we're sending out correspondence to patients to speed that process up. There's a contract management bit, which each customer sets up. These are the pathways I use. We talked briefly about the rules, or you've seen some bit about the rules management. And I guess the last thing I just wanted to show you quickly what we've done on the RPA side. And bearing in mind so every second week when we arrive in the office on a Monday, it's quite likely that the National Health Service has made a system change which they haven't notified us of in advance. So this is a little bit of operationalizing the use of. Obviously, if you control every system, you don't have to worry about this. But there's always a little bit of hectic on a Monday morning where we've moved our ops meeting to 10 o'clock because we want to get the updates on the RPA is all working, all the necessary changes. But I guess this is just a quick look. So what we have. So I said we are using automation anywhere, and then what we've started doing is building quite a lot of the alerts into Appian because it's easier for the operators, and obviously we want to delegate this internally as far down in terms of skilled stuff, and eventually we want to delegate as much of this as we can to the customer. So this basically shows the various bots, what it does, and what state it is in, and you can then drill down and get a sense of because the biggest challenge we've had with the RPA is really to know whether. We don't have the control numbers. We don't know how many referrals we were meant to receive. So that's and obviously we're talking about referring patients, and always a nightmare for us is to have patients that are stuck because the bot couldn't understand what to do next. So I think that's it from a kind of PowerPoint present. But Fritz, really keen to take questions, and some I may be able to answer, some I may not.
Perfect. No, Ingolv, thank you very much. That was fantastic. We appreciate that.